For the next oral presentation is study of the effect of SGLT2 inhibitors in delaying kidney deterioration in patients with chronic kidney disease or diabetic kidney disease with eGFR greater than 45 and no or mildly increased albuminuria, presented by Wachirawit Supasa from Medical Education Center, Phrae Hospital.
Okay, sorry the convenience before. Good morning, respected professor, commentator, and colleague. My name is Wachirawit Supasa, and a fourth-year medical student at Medical Education Center at Phrae Hospital, Naresuan University. Today, I would like to present our study, effect of SGLT2 inhibitors in delaying kidney deterioration in patients with chronic kidney or diabetic kidney disease. Data from the Nephrology Society of Thailand show a progressive rise in the demand for renal replacement therapy, which is straining our healthcare system. And the recent KidneyGo 2024 guidelines emphasize early management to address this issue. SGLT2 inhibitors are cornerstone of CKD treatment. They block glucose and sodium reabsorption in the kidney proximal tubule, reducing interglomerular pressure and oxidative stress, thus providing renal protection. While their benefits it prevent in advanced disease, evidence in early stages patients with normal to mildly increased albuminuria remain limited. Furthermore, there is a gap in real-world data regarding their effectiveness, specifically in Thai outpatient settings. This leads to our research objective to compare the hazard ratio for eGFR decline between patients receiving SGLT2 inhibitors and those who did not over a 3-year period. Our study is theoretic research analyzing an occurring relation where eGFR reduction is a function of drug use adjusted by confounders. The study design is a retrospective observational cohort study conducted at outpatient department of Phrae Hospital using data from the hospital database. Our domain includes CKD patients at Phrae Hospital. From the initial pool, we identified 319 eligible patients meeting inclusion criteria such as age older than 18 years, eGFR level more than 45, and UACR lower than 30. These also include patients who have type 2 diabetes, and we exclude patients with uncontrolled diabetes and uncontrolled hypertension. The study population was divided into two groups. The index group 159 receiving SGLT2 inhibitors and the reference group 160 not receiving the drug. Our primary clinical endpoint was a decline eGFR more than 20% from the baseline. We adjust our 4 priori confounders as shown on the slide. This is our study flow diagram. We follow eligible patients for 3 years until reaching clinical endpoint. And our study scheme shows recruitment starting on the 1st January 2021 and studying conclude on December 31st, 2024. For analysis, we use descriptive statistics for baseline characteristics, Kaplan-Meier curve and log length test for survival analysis, and Cox proportional hazard regression to calculate the adjusted hazard ratio. Verifying the proportionality assumption using Schoenfeld residual test. Here's our result. We found a significant difference between groups. Patients in SGLT2 groups were younger, while BMI and baseline eGFR were lower in non-SGLT2 group. This graph illustrates the cumulative incidence of event. The red line represents the control group, while the blue line represents the SGLT2 group. Our result demonstrates a clear divergence. At 1 year, the SGLT2 group show a crude cumulative incidence of 22% compared to the 32% in the reference group. And at 2 years, the incidence of SGLT2 group rose to 33, where the reference group reaching 55%. These are the results from the Cox proportional hazard regression, which was fully adjusted for all confounders. The study showed that SGLT2 inhibitor can reduce the risk of kidney deterioration down to 51%. That presents a hazard ratio of 0.49 on the slide. After adjusting for confounder, our final model used similar result, presenting the statistically significant hazard ratio of 0.49. The Schoenfeld test confirmed our proportional hazard assumption was valid. Our findings are consistent with pivotal study. The EMPA kidney trial report a hazard ratio of 0.64, while in our study is 0.49. This validates the renal predictive effect and theoretical nuclear gap in a population that had not been adequately studied before. The decision in the result likely stem from variation in study design and endpoint definitions. Another discussion point is the potential benefit. The gap in hazard ratio widening over time, emphasizing that early intervention is the key. This strategy likely cost-effective by preventing progression to ESRD and improving quality of life. Regarding the clinical implication, clinicians should consider initiating SGLT2 inhibitor in CKD stage G1 to G3A, in with normal to mild albuminuria to reduce morbidity and mortality. In conclusion, our study demonstrates that initiating SGLT2 inhibitors in early stages may be beneficial in preventing the progression to ESRD and reducing a long-term burden of renal replacement therapy. However, further study at multi-center or prospective cohort study are needed to confirm this finding and enhance the quality of the result. We would like to thank you to Assistant Professor Dr. Pakan Owatpun, Assistant Professor Dr. Porchailin Kamuntit, and the Phrae Hospital Digital Health Unit for their support. Thank you for your attention. I'm now open to questions.
That was a wonderful presentation. Do you have any comments or any questions?
Thanks for the excellent presentation. I would like to ask because you mentioned about SGLT2 inhibitors.
Yes.
Using in some patients but not in the others. So in your center, what are the clinical guidance or guideline to give the SGLT2 inhibitors to the patients? Because some receive, some did not.
This usually depends on the clinician judgment whether the patient can receive SGLT2 or not. Firstly, they must identify the patient that their eGFR level is meeting the criteria, which is not a ESRD level. And the second is about the financial status of that patient. Usually, patients who receive SGLT2 inhibitor are the ones that have the insurance using civil government insurer. But other patients can, but they cannot cover in them, so they have to pay out of pocket by themselves. So I think that's depend on the clinician. Yes.
Since this is a retrospective observational cohort design for 3 years, right?
Yes.
How do you control the drugs that patient takes?
We are analyzing the record from our database, and we control the patient who receiving SGLT2 inhibitor more than 3 years continuously, and we exclude those if they are not meeting the 3-year period. So
if the patient take, for example, they visit me 2 months ago and they take ACI or ARB, did you exclude this patient?
We did not exclude those patients.
So how do you tell us about, how do you differentiate about these two groups? Some people may need ACI or ARB, some people don't take ACI and ARB, and this drug can reduce the albuminuria.
Okay, all patients are already in the nephrology clinic, so they already received this drug ARB and ACI, and they are both have the same drug. Yes, they're taking.
You don't show the details of ACI and ARB in each group.
Oh.
In the presentation, you have show that. I'm not sure. That's okay.
Oh.
It's not different, right, between two groups.
We didn't see
The percentage of the patient that took ACI or ARB in two groups is not different, right?
Yes, not different because we take into the account of the using this drug. They are the diabetic mellitus patient and a chronic kidney disease. So both of them already using ARB.
And as you mentioned that SGLT2 is reimbursed, can be reimbursed in the patient who work for the government.
Yes.
So do you think this is a confounder of your study?
Yes, it is a very important confounder that we have to take into account because both groups are very different. But we adjust for another confounder to control that they're gonna be the real effect of the drug.
So if you think this is a confounder, you have to consider this a confounder.
Yes, we
before put in the statistical analysis.
Yes, one of our confounder is socioeconomic status that we taken in the model.
I understand it's okay in real life. Okay, sometimes you want to know the result, but at least you should put this in the limitation or in the discussion. It's fine. Okay, but should have that on the limitation in the limitation in discussion session.
Thank you for a useful information.